The previous two sessions have discussed about the effect of pregnancy on carbohydrate metabolism, the effect of diabetes on the mother and the fetus, and how to screen for diabetes in pregnancy. In this session, we will deal with how to manage a pregnant woman who is bound to have diabetes. Management of pregnant woman with diabetes is discussed in this session as in three parts. First part dealing with the woman who is already diabetic and planning for a pregnancy, what we know as the preconception counseling. Second part is about whether she is pre-GDM or GDM, how to control the diabetes during the antenatal period. And third part, I will discussing about the obstetric management of the woman. Women who are likely to develop GDM in pregnancy will be benefited by a preconception care. Those women who are obese, having PCOS, or there is a previous history of GDM in the first pregnancy, or a history of preterm labor, term intrauterine death, stillbirth, neonatal death, or a delivery of a baby weighing more than 4 kg. In such patients, there is a high risk of developing GDM as they get pregnant. And in this woman, they should be advised to have their body weight control and should be advised on lifestyle modification regarding exercise and diet control. And they should also be made aware about the acceptable weight gain during pregnancy. In a woman with a normal BMI, that is between 18 and 23.5, the acceptable weight gain is between 11 to 15 kg in pregnancy. And obese, overweight woman, that is between 23 and 27.5, the accepted weight gain is about 10 to 12 kg. And if she is obese, that is BMI is more than 27.5 and between 31, then the accepted weight gain is only 8 to 10 kg. And if the BMI is more than 31 to 35, the accepted weight gain is about 5 to 7 kg. And in morbidly obese woman, that is the BMI is more than 35, the permitted weight gain is only 4 kg during pregnancy. So this will help them to they also be aware of the various complications that can result if they develop GDM to the mother and the fetus. This will motivate them to have an ideal body weight and change the lifestyle modification. Coming to antenatal glycemic control, the primary line of management is diet control and exercise. Diet control, properly known as medical nutrition therapy. If the target hypoglycemic level is not achieved, then we go for the second line, which is adding of hypoglycemic drugs along with exercise and diet. The objective is to bring the blood glucose levels to as near as normal without going for a hypoglycemia. This is because it has been founded by studies that complications are directly proportional to the blood sugar level. And the target blood sugar level we aim at are a fasting blood sugar level of less than or equal to 95 milligram percentage, and the postprandial value of 1 hour less than 140 milligram percentage, and the 2-hour value less than 120 milligram percentage. And we will go into details regarding the different modalities. Regarding diet control, when you advise on diet control, for a woman, the first thing you have to remember is if you prescribe a very totally unfamiliar diet for the woman, most often she may not be compliant. So better to have a diet history of the woman herself and ensure that she requires adequate calorie in required proportion, and also it contains sufficient vitamins and minerals. The calorie intake will be depending on the body mass index of the woman. For a woman having a normal BMI, you can prescribe 30 kilocalories per kg. If she is obese or overweight, it should be reduced to 22 to 24 kilocalories per kg and 15 calories per kg for a morbidly obese woman. Remember, when you calculate the BMI, you should take into consideration the pre-pregnancy weight. And the proportion of nutrients are carbohydrate around 40%, protein 20%, and fat 40%. And we all know in pregnancy there is fasting hypoglycemia and postprandial hyperglycemia. To avoid these fluctuations in the blood sugar level, it is better to give more frequent small diet. So usually we prescribe 3 main meals: breakfast, lunch and dinner, and 3 snacks, one in the mid-morning, other at 4 to 5 p.m. and the third snack at bedtime. And she should also be advised there should not be any fasting or overeating. This is to avoid again the fasting hypoglycemia and postprandial hyperglycemia. And when she selects a carbohydrate, that it should be selected in such a way that it should be a low glycemic complex carbohydrate, so that will avoid postprandial hyperglycemia. And she can also advise to take fruits, especially low glycemic foods like guava, apple, gooseberry, and grapes. The high glycemic fruits like grapes may be taken in 2 or 3 or one orange, like that, so that she may not be deficient in vitamins and minerals. Exercise, along with the diet control, is considered as a first-line management for diabetes. If a woman is in the habit of taking regular exercise, she can continue with that. If she is not on any regular exercise, advise aerobic exercise like walking 30 minutes per day at least 4-5 days a week. Those cannot walk, you can advise upper body exercise. Exercise help in reducing the blood sugar by increasing the glucose uptake by muscles. It decreases the insulin requirement and thereby achieving better glycemic control. It is important to know whether your management has helped in achieving glycemic control. So for assessing glycemic control is very important. After 2 weeks of medical nutrition therapy and exercise, check the blood glucose level. The target blood glucose level aimed at are fasting blood sugar less than or equal to 95 milligram percentage. If you are taking a 1 hour postprandial value, it should be less than or equal to 140 milligram percentage. Or a 2 hour postprandial blood sugar should be less than or equal to 120 milligram percentage. If target blood sugar level is achieved, then it is well and good. You can continue the same regime and has to be repeated. Repeat check-in should be done after 2 or 4 weeks. If the target is not achieved, That means the medical nutrition therapy and exercise is not sufficient to control the glycemia. Then you had to add hypoglycemic drugs. When we think of hypoglycemic agents, we can have two choices. One is to put her on insulin or to put her on oral hypoglycemic agents. How to choose in between? If we prefer for an insulin, what are the problems? That means she has to get multiple injections, which may not be acceptable to the woman, and she has to be educated regarding the administration of insulin. That means she may have to administer to take self injections. Insulin may require refrigeration, and she also should be able to do self monitoring of glucose. Insulin also causes maternal weight gain, and one of the side effects is hypoglycemia, and the woman should be educated regarding how to recognize hypoglycemia. Regarding oral hypoglycemic agents, another two drugs we commonly use is the metformin and glibenclamide. Metformin can be used in the dose of 500 to 2000 milligram per day, and even though it crosses the placenta, there is no ill effect have been found on the fetus. It is a good choice for obese women because it will not cause any weight gain, in contrast to insulin. Hence, it also reduces the chance of large for gestational age or macrosomic fetuses. But one problem with the metformin is the glycemic control may not be optimum for 50% of the women, and they may require additional dose of insulin. Glibenclamide is another drug which can be used during pregnancy, and the dose is 2.5 to 20 milligram. But there is an increase in the incidence of macrosomia and neonatal hypoglycemia when we use glibenclamide. Hence, it is not commonly used. Even though we can use insulin as well as oral hypoglycemic agent, depending upon the preference and individual patient, in certain conditions, insulin is more preferred. When the fasting blood sugar and postprandial blood sugar is very high at the time of diagnosis, or if she is having pre-gestational diabetes mellitus, or if there is a history of previous preterm delivery, macrosomia, intrauterine death, or a neonatal death which we suspect due to diabetes. In such cases, better to put her on insulin. And in this pregnancy, already there is complications of diabetes like polyhydramnios, macrosomia, or if the hypoglycemic agent is required in the third trimester, where you want a rapid control, then also we prefer insulin rather than oral hypoglycemic agent. When you opt for insulin, then the question is what type of insulin you give, whether it is a human insulin or a bovine insulin, is it short acting, long acting, or intermediate acting, etc. So in pregnancy, we prefer only human insulin, and usually for the better control, we use an intermediate acting insulin, and if it is not controlled, we may add a short acting insulin, and usually we don't prefer a long acting insulin. It may be difficult to control the blood sugar level in pregnancy. And so to start with, we give intermediate acting insulin like NPH or Mixtard, and or a combination of intermediate and short acting. If you are giving a combination, it should be in the ratio of short acting 30:2 and a long intermediate acting 70 in the morning, and 50-50 ratio in the evening. Usually twice daily doses will be sufficient. and still there is postprandial hyperglycemia, you can add short-acting insulin just before food. And the insulin should be given half an hour before food. And this timing, whether to give along with food depending upon the type of insulin we use. If we are using regular insulin or intermediate acting insulin, should be given half an hour before food. But if the newer insulin like Atrapid, Lispro, etc. used, then you can be given just before food or along with food. And if the woman is on insulin, she should be educated regarding self-monitoring of glucose, and the glucose should be checked fasting 1 hour or 2 hour postprandial blood sugar till it is well controlled, and that should be done daily. And once the sugar is controlled, then the checking may be reduced to twice in a week or once in a week. And remember, the glucometer you have to standardize. So it is better to cross-check with the lab value once in a month. So far we discussed about getting glycemic control by different modalities, mainly medical nutrition therapy plus exercise, and if not controlled, by adding hypoglycemic agents. Now we come to how to manage the pregnancy in a diabetic woman. I already said there are two types of diabetes. One is where the diabetes is present even before pregnancy, called BGDM, and a woman who develop diabetes during pregnancy. We will deal with gestational diabetes first. In GDM, the risk of congenital anomaly, abortion, and ketoacidosis is not increased because most of them GDM is developed in the second and third trimester. And usually diabetes may be mild, and majority get controlled with medical nutrition therapy and exercise. And in a well-controlled gestational diabetes, the risk of stillbirth is minimum and macrosomia is uncommon. With this basic knowledge, we manage a gestational diabetes woman. So first we do a dating scan, preferably between 18 to 10 weeks, and try to achieve glycemic control. We have to do an anomaly scan at 18-20 weeks, and after that evaluate the fetus for macrosomia at 28 and 32 weeks by USG and looking for the biometric. If she is controlled with diet and exercise alone, then she is classed as GDM class A1. And if there is no complication, that is, a GDM patient controlled on diet and exercise, and there is no complications like hypertension, any fetal complications like macrosomia, polyhydramnios, or IUGR, then we can continue the pregnancy up to 40 weeks. But we don't allow her to go past it. We see that she delivers at 40 weeks. Class A2 GDM, that is, those GDM patients whose glycemic control is achieved only with the oral hypoglycemic agents or insulin. They are called GDM class A2. And along with class A1, where there is complications like preeclampsia, gestational hypertension, or polyhydramnios, macrosomia, IUGR, such patient there is an additional risk of fetus having hypoxia. So they need, in addition to the other management, the fetal well-being test, which should be started from 32 week onwards, and it is done by a twice weekly NSD and a weekly biophysical profile starting from 32 weeks onwards, and this patient should be delivered at 38 weeks. Regarding the mode of delivery, both class A1 and A2, the indication for cesarean is only obstetric indications like abnormal lie, abnormal presentation, contracted pelvis, placenta previa, etc. It is called obstetric indication. In addition to that, diabetes per se, the indication is when the fetus is having macrosomia, that is the estimated fetal weight is more than or equal to 4 kg. In all other cases, we prefer vaginal delivery. Now, how to manage this patient during labor? As in all patients, we have to monitor the progress by a partogram, in which we will record the uterine contractions, descent of the head, and cervical dilatation. Regarding the fetus, even though in the antenatal period there may not be any hypoxia, when the uterine contraction starts, there may be chances of hypoxia to the fetus. So, electronic fetal heart rate monitoring is needed, and always anticipate fetal distress, meconium stained amniotic fluid, and for the as the labor is may fail to progress due to failure of descent, since there may be a chance of CPD, and always anticipate shoulder distortion. And the glycemia or the blood sugar level should be meticulously controlled during labor. And we all know during labor there may be restriction to the food intake. We don't prefer solid foods, and one may be aversion, they have an aversion to food, and there may be often vomiting. So you have to check the blood glucose level frequently by a glucometer and maintain the blood sugar level between 70 to 130 milligram per deciliter. And remember, we withheld insulin. If the patient is on insulin, the morning dose of insulin will be withheld on the day of labor or on the day of induction. And you have to repeat the blood glucose level every 2 to 4 hours and maintain it within the range. And if it is going below 70, we have to add 5% dextrose, or if it is going above 130, we have to give regular insulin so that the blood sugar is within the normal range. And you have to also check the urine for any ketone bodies. In the third stage, beware, these patients are more prone for primary postpartum hemorrhage. Both types, both atonic and atraumatic postpartum hemorrhage can occur. So, active management of third stage of labor should be meticulously followed, as well as the genital tract should be explored for any traumatic bleeding. In the postpartum period, her insulin requirement will be drastically reduced, and there may not be no need at all. And blood sugar is controlled, tested for after 24 hours of delivery. In spite of no requirement of insulin, her diet and exercise better to be continued in the postpartum period also. And at 6 weeks postpartum, a 75 gram GTT is done. And if it is abnormal, that means she is not having GDM, or it is a pre-gestational diabetes, and she needs consultation with a physician. If 75 gram GTT is normal, you can confirm that she is having GDM, and now you can ask for a annual testing. That is because there is a danger of she becoming diabetic in the near future, that is within 5 to 10 years. To prevent that, lifestyle modification, and that is diet and exercise should be continued in all of her life. We have discussed the obstetric management of GDM patients, that is, those women who develop or detect diabetes during pregnancy. What if she had already diabetic before pregnancy, what we call as the PGDM, or patients who are over diabetes? Who are over diabetes means patient having PGDM but not detected prior to pregnancy. So in these patients, there will be the glycemia will be under control, not under control during the embryogenic period. So that may result in more fetal complications like congenital anomalies and abortion. And mother may have, depending upon the duration of diabetes, there can be micro or macrovascular complications, which may result in nephropathy, retinopathy, coronary artery disease. Remember, all the complications we discussed earlier regarding GDM can also occur in PGDM also. In addition to that, the above mentioned complications you have to be aware of. In those women who are diabetic even before pregnancy, their obstetric care should begin in the pre-conceptional period, and they need a pre-conceptional counseling. And during this period, they should be evaluated for glycemic control. If it is uncontrolled, better to control and get delivery and get conception after that. And these women are more prone for complications due to macro or microvascular disease, mainly of the renal, retinal, and cardiac diseases. So they have to be evaluated for the function of the kidney, fundoscopic examination for any proliferative retinopathy. If it is there, should be treated promptly, and the evaluation of the cardiac status. And if the woman is on oral hypoglycemic agent, there is a risk of teratogenicity, and you have to put her on insulin. And if she, the only exception is metformin. If she is only on metformin, that can be continued. And majority of these women may be having other diseases like hypertension, dyslipidemia, may be on different medication. So you have to review the medication and see whether there is any embryotoxic drugs and should be changed to safer medication. And they should be educated regarding the need for strict glycemic control during pregnancy and even preconception, and should be made aware of the fetal and maternal complications. They should be taught that since they are put on insulin, they should be taught regarding the self-injection of insulin, regarding their storage and self-monitoring of blood glucose level. And you have to check for the preconception glycemic control by a fasting postprandial as well as a glycosylated hemoglobin. Now, if the value of glycosylated hemoglobin is more than 10, better the pregnancy is deferred until her glycosylated hemoglobin level come to less than 6.5%. And the fasting and postprandial blood sugar should be within the normal range. And since these patients have high risk for neurodevelopmental defect, they should receive periconceptional folic acid. Regarding antenatal glycemic control, Majority of them may need insulin for control. So if the patient, they can be tried on medical nutrition therapy and exercise. In addition, there will be a need of hypoglycemic agent. An oral hypoglycemic agent is not preferred, but if they are already on metformin, that may be continued. And regarding insulin, they may require short-acting insulin for control of diabetes, or it should be a combination of intermediate acting and short-acting insulin. The newer insulin analogs may be used, but long-acting insulin analogs are not preferred since it may cause since you can expect fluctuation in the blood glucose level. Again, for monitoring of the glucose, fasting postprandial, as we do in a GDM patient, may not be sufficient because there may be fluctuation throughout the day. So often you have to resort to a glucose profile, which means you have to take a fasting blood sugar, postprandial blood sugar after breakfast, lunch, dinner, and another random blood sugar at 5 p.m. and 3 a.m., which will give you roughly the around 24-hour glucose value of the blood, and according to that you have to control the blood sugar, and you have to repeat daily self monitoring of glucose will be required in this patient. When they are seen in the first trimester, they should be again evaluated for glycemic control and end organ dysfunction. If they haven't came for a preconception counseling, this time should be used for a counseling, as we have already mentioned in the prenatal counseling or preconception counseling. And regarding the pregnancy, we have today dating scan for accurately dating the pregnancy, because she may need a earlier termination. NT scan should be done at 11 to 13 weeks and should be combined with an aneuploidy screen in the first trimester. In the second trimester, as usual, you have to do an anomaly scan, and since these patients are more prone for congenital anomaly and cardiovascular abnormality being the most common, they are in need of a fetal echo at about 24 weeks. And there is a high chance of developing preeclampsia in this patient. So close monitoring of blood pressure is also necessary. In the third trimester, close monitoring of the BP should be continued, and special attention should be given to the symphysis of underlying height to detect macrosomia and fetal growth restriction. Also, there is a chance of developing polyhydramnios and inquire regarding the symptoms of vaginal discharge. Because there is a high chance of developing vulvovaginal candidiasis. And the fetus should be evaluated for fetal well-being by USG from 28 week onwards, and it should be repeated every 2 to 4 weeks for growth. If there is FGR or uncontrolled sugar, and the USG should be repeated every week. And if found to be fetal growth restriction, it warrants a Doppler examination of the umbilical and middle cerebral arteries. Also, and you have to look for any polyhydramnios. For to detect, there is a high chance of fetus developing hypoxia. Hence, there should be fetal well-being tests like NST, which is repeated every third day, and a biophysical profile every week. And the estimation of fetal weight should be done to detect FGR or macrosomia. When to deliver this woman? When you consider the time of delivery, you have to balance between prematurity when you terminate early, or the delivery is delayed, there will be more increased perinatal loss. So you have that has to be a balance between prematurity and increased perinatal loss due to delay. And usually in PGDM patients, when it is controlled by insulin, pregnancy is advised to terminate by 38 weeks. If it is poorly controlled, better to terminate between 37 and 38 weeks. If there is a complication, either fetal or maternal complication, and the time of termination is dictated by complication. And regarding the mode of delivery, the only indication for CS is obstetric indication and macrosomia more than 4 kg. In Indian women, shoulder dystocia may be there even with a fetal weight of greater than 3.5 kg. All others, vaginal delivery is preferred. Regarding intrapartum management, it's essentially the same as patients in a GDM. We stop insulin on the day of labor or on day of induction, and here the glycemic control should be very meticulous and more closer monitoring of glucose, because there may be more prone for hypoglycemia as well as hyperglycemia. So hourly glucose monitoring is a must, along with urine for ketoacidosis. Coming to the postpartum period also, the insulin requirement will be drastically reduced, and you have to adjust the dose according to the glycemic level. And in the postpartum period, she may be put on, if she wants, she may be put on oral anti-glycemic drugs. Now, this woman may need a contraception. So, what is the contraception preferred in this woman? There is no contraindication for low dose combined oral contraceptive pill, or you can opt for an intrauterine device in a GDM patient. For a pre-gestation diabetic patient, there is a more chance of thromboembolism. So the preferred contraceptive is intrauterine device. So overall, for a diabetic woman, intrauterine device is an ideal contraceptive. In short, the key to management of diabetes in pregnancy is to give meticulous attention to the glycemic control, paying attention to detect the growth abnormality in the fetus and doing fetal well-being test to detect hypoxia during antenatal and intrapartum period will go a long way in preventing the maternal morbidity, fetal and neonatal mortality and morbidity. And the complication can be reduced to as near as normal to a normal patient.